Okay, thank you, Mr. Chairman. I'll present three sexual complaints that we think are sort of culture-specific, meaning that we see a lot of them in the Middle East. So why should these complaints be culture-specific? In most conservative societies in the Middle East, there is no formal sexuality education, and all the information young people have are through unofficial sources, internet, peers, elder brothers and sisters. So in such an environment, myths and misconceptions prevail. There's a lot of myths about masturbation. Actually, before I came here, a colleague of mine showed me a book published and being sold on the streets in Cairo about the 99 diseases caused by masturbation. The importance of the size of the penis is overemphasized in our culture, and I'll show you why do I think. Of course, in many cultures, the body dysmorphic disorder is an important problem, but I think we see it more than in other cultures. And another thing that's culture-specific is the possible difficulties penetrating the hymen during the honeymoon. Actually, a lot of men are very afraid that the hymen might be rigid, so they will have problem in achieving vaginal intromission. Of course, these guys, they don't have any sexual experiences before. Women are very afraid that this might be a very painful experience, so we see a lot of vaginismus there. And there are other problems like the involvement in the family. Almost everybody in the family, the next day after the wedding night, one would like to know whether the mission was accomplished or not. So the body dysmorphic disorder is a very common complaint. I'll show you some slides about that. The unconsummated marriage, or commonly referred to as honeymoon impotence, will be the main focus of my talk. Prostaturia and seminarrhea are also very common, but I was curious to know, is anybody here in the audience familiar with this term? If anybody have heard the term prostaturia, would you please raise your hand? Okay, so there's one person. Dr. Anand, thank you. So this is a very common complaint. This is the most common reason for the complaint of urethral discharge in the Middle East. Typically, that's a young man who doesn't have sex and doesn't masturbate. And he complains of urethral discharge. The discharge is characteristically related to the urine. It comes after the urine or when there is increased intra-abdominal pressure, like during defecation. And the discharge resolves with masturbation. We just advise them, why don't you test masturbate, and the discharge disappears. It's a serious issue, and the patients typically are very distressed, and they think that they're suffering a serious illness. And they're easily reassured. And I think there is also an overlap with the so-called Dutch syndrome, which I believe some authors assumed, because there are no physical signs of this disease, that it is a mental disorder, and classified it as a mental disease. Another complaint is excess secretion during sexual arousal, which illustrates the amount of, or the lack of sexuality education. Patients are afraid of or concerned about their pre-secretions. So are some societies still held up on the age-old myths about penile size? Well, the largest two studies about the body dysmorphic disorder regarding the small size penis come from Egypt. One was published by me and a group of colleagues in the Journal of Sexual Medicine. It constituted 250 patients collected over a 2-year period. And Shamlul, my colleague who's in Canada now, he also collected 92 cases in 1 year when he was in Cairo University. So what's the difficulty with the body dysmorphic disorder? Most patients are physically normal. They're very hard to convince and usually insist on medical or surgical interventions. They frequently fall victims of the enhance your penis ads and unnecessary surgery. I need to point out something here about the claims of the surgeons doing this sort of penile augmentation procedures. These surgeons are assessing their own results. So there is no independent audit, so really the results are based on the surgeon's own interpretation of his results, which is clearly biased. There will be a session about the body dysmorphic disorder tomorrow at 5:30, and Dr. Pera Salian and myself will discuss this disorder in more detail, and Dr. Salian will discuss the olfactory reference syndrome. I'm not familiar with this syndrome, so Pierre will give us much more detail about that. So is it an overstatement to say that honeymoon impotence is an epidemic in the Middle East? Well, Miligi in Saudi Arabia published that 17% of the patients presenting in his sexual dysfunction clinic in Jeddah suffer from honeymoon impotence. In my series, in another series by Dr. Ibrahim Fahmy in Cairo, published in the Journal of Sexual Medicine and in the International Journal of Sexual Impotence Research, the incidence was 8% of patients attending sexual dysfunction clinics. And in Turkey, Özdemir published that 24% of patients presenting within a sexual dysfunction clinics are presenting with unconsummated marriage. What's the cultural background for this? As mentioned, couples have limited sexual experiences. Failure will not only lead to embarrassment with their wives, but also humiliation with the bride's family. So all those people in this picture will probably know about the failure next day. And thus it's a medical and social emergency to resolve it as quickly as possible. Most of the literature about unconsummated marriage is coming from the Middle East, Egypt, Saudi Arabia, Turkey, Iran, and Pakistan. So the time of presentation is generally early because of the stress. So a third in the first week and another third within the first month. But it might take longer, and actually I've seen patients waiting up to 40 years with an unconsummated marriage. So the etiological factors in Dr. Ibrahim Fahmy's study, it was that the organic factors were only in 7% of cases. 75% were mainly performance anxiety and some premature ejaculation. And vaginismus was around 8%, which was similar to my series. However, Shamlul reported a high incidence of physical disorders, up to 25%, a quarter of the patients. And Osta in Turkey reported that the third of them had physical disorders. I really would challenge these things, and I'll show some slides why I believe that still most of these patients are suffering a primarily psychogenic erectile dysfunction. What's really surprising is Özdemir's study from Turkey, where contrary to our 8% result suggestion that vaginismus is the problem, 80% of his cases were vaginismus. It's not clear whether this because of the nature of his clinic, that perhaps most of his cases were referred, or that we might be underdiagnosing vaginismus in Cairo, or perhaps Turkish men are more scary than us, I don't know. So the typical case, let's call him Adam, it's just a nickname we chose to refer to numerous patients with this condition. He frequently had full rigid morning erections and erections on watching any sexually stimulating scene. He was not involved in premarital sex due to cultural and religious reasons. On the wedding night, he was tired and exhausted from all the preparation, and he lost his erection and it failed. Clearly it is psychogenic, and education, reassurance, and perhaps PDE5 inhibitors for a short course could have resolved it. But unfortunately, he went to a physician who ordered some tests and turned out with a positive finding of a venous occlusion dysfunction, and he was advised surgery. Unfortunately, this is very common. It's an example of unnecessary prescription of investigations, false positive results, dogmatic interpretation of the results, and faulty medical advice. The right thing to do, I'll show in later slides, is to follow a patient goal-directed approach and only order tests that are going to help in the management plan. This approach has been published by Dr. Tom Liu, who gave the first presentation this session, and I think it is the wisest approach. The evaluation is mainly a complete sexual and medical history, exclude risk factors, ask about non-coital erections in the morning and in other non-coital situations, exclude vaginismus and the very rare anatomical abnormalities in the vagina, and keep in mind that an erroneous diagnosis of a physical disorder in a young man would have disastrous effects, because this man is here, he needs reassurance and he needs education. If instead of that you tell him you have a problem and you need surgery, it's going to be disastrous. So are the vascular investigations reliable in diagnosing a physical etiology, while vascular tests are based on obtaining maximum smooth muscle relaxation to allow the blood flow and to occlude the veins? With the anxiety there, we frequently get false positive results. I will not go into the details of the test, but we mentioned this paper. We published this paper recently in the Journal of Sexual Medicine regarding the evidence-based perspective to the commonly performed ED diagnosis or investigations, and we challenged most of the results because of the unknown positive predictive factors of most of them. Laboratory investigations, I didn't do all those tests routinely until a few years ago. I missed a prolactin secreting adenoma that was diagnosed by a medical student who suggested that the patient would do it, and I was just treating him with PDE5 inhibitors. So from then on, I ran the first three tests: the blood sugar, the testosterone, and the prolactin. Questionnaires will turn out, of course, diagnosing severe ED because these men never maintained an erection for intercourse. They're never confident and were never satisfied, the honeymoon impotence patients. Education is the most important factor, and as I showed you the first slide about the sexual position, psychosexual therapy could be combined with PDE5 inhibitors. Vaginismus could be treated with vaginal dilators or otherwise. And lastly, intracavernous injections. We show the patients simplified illustrated educational material explaining the male and female anatomy. The concept of performance anxiety is explained. It's very important that the patients would get insight that fear of failure would cause failure. And the myths regarding the hymen, that it's not such a terrible barrier, and really it doesn't exist. These are just folds of mucosa, and there isn't necessarily any bleeding on the first night. And sex positions, we advise the missionary position to start with. Education is important. Actually, education not just for the wife and her husband, but for the family, because we frequently get several family members there, and on one occasion had 12 aunts and uncles in the room wanting to see who's to blame. So there is no attempt is made to point the blame on either the male or the female, and we explain that some fear or resistance on part of the wife, with added anxiety on part of her husband, would trigger the performance anxiety cycle. We cannot go into real sex therapy there, but what we advise them is just to take the PD5 inhibitor, and we ask them not to try to have vaginal intermission for 2 weeks. During those 2 weeks, we advise mutual stimulation, genital touching, and introducing just the glands of the penis or the head of the penis between the labia majora, or just at the introitus, to remove the anxiety related to the sexual act. And as I'll show you now, this approach seems to be working well for us. Before there were PD5 inhibitors, used intravenous injections, which almost always worked up to 93% of cases, except when there's severe vaginismus. And I'll skip this ask. Regarding the sildenafil, was the second step we took after the intravenous injections. Now it is the first line of treatment after education. This modified sex therapy I suggested is the PD5 inhibitors. So in this case series of 35 men, we were successful in 90% of the cases. The treatment failures were treated with intravenous injections. In Shamlul's study, almost all psychogenically impotent patients responded to PD5 inhibitors, sex therapy, and education. Even vasculogenic cases, most of them responded. And only 4 cases out of 100 were diagnosed as venous or required surgery. And I really doubt that all these cases were physical. We used alternate day tadalafil treatment because tadalafil is longer acting, so we assumed that it would be easier to withdraw because the patient would feel more spontaneous during intercourse, and the tadalafil will work for 36 hours. So this is what we do now. The study was on 45 patients. Of course, we went through the education, the mild or the modified sex therapy, and we again were successful in 90% of cases. The rest were resolved with intravenous injections and vaginal dilators. This study comes from Zargushi in Iran, is really puzzling to us, that while we are describing success rates with PD5 inhibitors up to 90%, in his experience, only 8% of his patients with unconsummated marriage responded to PD5 inhibitors. And they strongly advised intravenous injections as the first-line treatment for unconsummated marriage, and they published that in the Journal of Sexual Medicine. And because this paper was published after ours meaning my papers, Shamlul's papers, Amr Mnigi's papers, and Ibrahim Fahmi's papers, his explanation that the 4 of us belong to the same institution, so perhaps we have some magic in the Department of Andrology in Cairo. But this paper from Pakistan, published in 2009, they obtained similar success like ours with education and PD5 inhibitors. So to summarize, honeymoon impotence is common and preventable. Multiple cultural factors contribute to the problem. A proper medical and sexual history are the keys to diagnosis, and there's a lot of false positive results with vascular investigations. Sex education is the #1, followed in our opinion by on modified sex therapy in addition to the PDE5 inhibitor. Vaginismus must be evaluated and managed. Intracavernous injections and surgery are reserved to our treatment failures, and we need randomized controlled trials to get final conclusions about what's the best treatment approach. Okay, thank you very much.